Hey everyone, today we are discussing a very important topic for each and every medico. Each and every medico needs to know how to manage this condition. This condition today we are discussing is called DKA, Diabetic Ketoacidosis. Before going into the discussion, I'll just give you a case to understand how they present to us in the casualty. So looking into the case, we have a 21-year-old male, known case of type 1 diabetes, presents with nausea, vomiting, pain abdomen, and frequent urination. On examination, the pulse rate is 112 per minute, BP is 110 by 60 mmHg. He has a small type of breathing and slightly lethargic. And he has been frequently missing his insulin doses. So we have a patient, a 21-year-old male who is a known case of type 1 diabetes, presenting to the casualty with nausea, vomiting, pain abdomen, and frequent urination. And he has been frequently missing his insulin doses. Upon examination, his pulse rate is 112 per minute, BP is 110 by 60 mmHg. Small breathing is present where the patient is rapidly breathing and the patient is slightly lethargic. And his laboratory data was RBS was 540 milligram per deciliter and pH 7.1. Bicarbonate is 12 and anion gap was elevated and blood ketones more than or equal to 3. So this is the patient. As we have seen the presentation of the patient, and upon evaluating further, his blood sugars were 540, which were very high, and his pH is 7.1, bicarbonate is 12, and anion gap was elevated, and blood ketones on the ketone meter were more than 3 millimole. We consider the patient as having diabetic ketoacidosis in the current clinical context. So how are we going to manage this patient? Looking into the criteria of diabetic ketoacidosis. Criteria. Blood glucose should be more than or equal to 200 milligram per deciliter. And then pH should be less than 7.3. Bicarbonate should be less than 18. And blood ketones should be more than or equal to 3 millimole per liter. So this is the criteria for diagnosing DKA. Blood glucose should be more than 200. pH should be less than 7.3. Bicarbonate less than 18. Blood ketones more than 3. And then elevated anion gap. Now coming into the etiology, stress usually precipitates decay. Could be due to missed doses of insulin, any infection, stroke, drugs like SGLT2 inhibitors, steroids. So coming into the etiology, stress can precipitate decay. Causes could be missed insulin doses, infection, stroke, MI, SGLT2 inhibitors and steroids are drugs which can precipitate decay. Pathogenesis. It is due to reduced insulin and high counter-regulatory hormones. Hormones like glucagon, cortisol, catecholamines, and growth hormone. In a stressful state, the counter-regulatory hormones are increased. The counter-regulatory hormones are glucagon, cortisol, catecholamines, and growth hormone. In a type 1 diabetes patient, he usually is insulinopenic where the insulin levels are low. And if he is frequently missing his doses, the insulin level comes down. And then when he has any acute stress like infection or any drug, he can have counter-regulatory hormone excess like glucagon, cortisol, catecholamines, and growth hormone. As a result of this, there is increased lipolysis. Free fatty acids are increased, and then these go to the liver where they undergo beta oxidation and produce ketones. So when there is increased lipolysis, there is free fatty acid excess. They go to the liver, undergo beta oxidation, and produce ketone bodies. Usually in decay, beta hydroxybutyrate is 5 to 10 times more than acetoacetate. With the blood ketone meter, we detect beta hydroxybutyrate. In the urine, we detect acetoacetate. So for diagnosing DKA properly, it is better to check blood ketones where we are measuring beta hydroxybutyrate than urine ketones where the ketone bodies could be falsely low upon checking the urine ketones. So we check beta hydroxybutyrate and it should be more than or equal to 3 millimole per liter. But upon treatment, acetoacetate increases and then can be detected in the urine. Urine ketones stay positive despite recovery. So how are we managing a patient of DKA in the casualty? Any patient in casualty, we start with assessment of airway, breathing, and circulation. Place two large bore IV cannulas. And then fluid replacement, ideally with normal saline. And then check potassium, which is very important. We shall be discussing it subsequently. And then insulin infusion. So with respect to fluid management, usually in a patient with DKA patient can have a fluid deficit of 6 to 9 liters, usually 100 ml per kg. A fluid deficit of 6 to 9 liters can be seen in a patient of DKA. It can be due to the dehydration, the vomiting, or the lower intake, osmotic diuresis, etc. The preferred fluid is normal saline. Normal saline is preferred. We usually give 500 to 1000 ml over first 1 hour and then give the remaining fluid deficit, 50% of remaining deficit over 8 to 12 hours and the rest 50% over next 24 hours. Your initial laboratory workup includes blood glucose, VBG or ABG, serum electrolytes, especially for potassium, and then renal function test, any infection screening, and also review the medication. Review the medication of patient. Drugs like SGLT2 inhibitor, steroids, and you can also do an ECG to look for any potassium related ECG changes. And also you need to check for blood ketones. Blood glucose every 1 to 2 hours upon starting treatment and electrolytes 2 to 4 hours. As we infuse the fluid, the renal perfusion improves, the blood glucose elimination also improves, the ketones are also washed away. And then one of the most important step is to check potassium before administering insulin. Potassium. If it is less than 3.3, hold insulin. If potassium is more than 5.5, start insulin and monitor. If it is between 3.3 to 5.5, start potassium replacement plus insulin. You give 20 to 30 millimole potassium per liter of IV fluid. Okay. So when the potassium is less than 3.3, you need to hold insulin. Absolutely, you need to hold the insulin. When it is more than 5.5, you can start the insulin infusion, and you need to regularly monitor the potassium, where 4th hourly or 6th hourly potassium monitoring is mandatory in the initial phases at least. And then when the values of potassium are between 3.3 and 5.5, you can start potassium replacement plus insulin infusion. Potassium replacement, you give 20 to 30 millimole per 20 to 30 millimole potassium per liter of the IV fluid we are giving. So coming to the insulin therapy, we start the infusion at 0.1 unit per kg per hour. No insulin bolus. For example, you start insulin in 1 ns. When the sugars are less than 250, you start insulin in 5% dextrose. The target blood glucose is 150 to 200. This is the target blood glucose. And then usually upon initiation of the insulin infusion, there will be 50 to 100 milligram per deciliter reduction in blood glucose in the first 1 hour. And bicarbonate is usually not given. Bicarbonate is given only when pH is less than 6.9. So bicarbonate is given only when the pH is 6.9. So we continue insulin as per the blood glucose, and we have to look for the resolution of DKA. The criteria for resolution is blood glucose less than 200, pH more than 7.3, bicarbonate more than 18, anion gap is closed, and blood ketones normal. So the criteria for resolution of decay is blood glucose less than 200, pH more than 7.3, bicarbonate more than 18, anion gap should be closed, and blood ketones should be normal. You can start food to the patient when the patient is hemodynamically stable, able to tolerate oral feeds, and patient's vomiting, nausea, pain abdomen has subsided. And always, before stopping the insulin infusion, it is ideal to give long-acting basal insulin 1 to 2 hours before the stopping of insulin. Long-acting basal insulin before stopping insulin infusion. So you give Glargine, for example, 2 hours before stopping the insulin infusion, and then switch to subcutaneous insulin. You can start food to the patient when the patient is hemodynamically stable, the pain abdomen vomitings have subsided, and patient is willing to eat, and when the patient is able to tolerate food. So in summary, what you need to know is DKA, blood glucose more than 200, pH less than 7.3, bicarbonate less than 18, blood ketones more than or equal to 3, and anion gap is high. In the treatment aspects, always fluids first, followed by potassium, and then only comes insulin. So this is it for today. We have seen the management of a very important condition in our regular practice. So DK management should be on your fingertips. I hope you could understand the topic well. If you have any doubts, put it in the comment section. If you have any suggestions or topics to be discussed, you can put it in the comment section. Happy learning. Thank you for watching the content. Please do subscribe. Thank you.